So we have some time to take some questions from the audience for any of the presenters from the morning sessions, Dr. Rossano, Dr. Lynn, and Dr. Owens. So just you can raise your hand and we'll come around with the mic.
Hello, thank you for your presentation. It's excellent. I just had a question because I know a lot of people this morning mentioned about Ernesto, which I understand is the brand name for valsartan. Is that right?
It's a combination. So Entresto is a combination of valsartan and a new drug called sacubitril.
Okay,
So it includes valsartan, but it adds a new drug to it.
Thank you, because I was like, wait, I didn't know.
Yeah, I've seen that, yes.
But also because I didn't know, so that's unrelated to the valsartan recall that was happening?
Yes.
That was my question about the recall.
Yeah, no, it's a great question.
Okay.
So a few of the angiotensin receptor blockers, like valsartan and its cousins, losartan, irbesartan, there's a few of them, they usually end in sartan, have had a recall, mainly due to impurities that were added during the manufacturing process. So the drugs themselves are safe and effective, but depending on where they're manufactured, if other impurities get into the manufacturing process, those impurities and chemicals can be toxic and cause harm. So what they found through testing, the FDA and regulation, is that some of the drugs that are being marketed are not pure, and that's the reason for the recall. So valsartan itself is very safe and effective, and in combination with this new drug, sacubitril, it's now marketed as Entresto. So if you start Entresto, you no longer need your valsartan or your losartan or your lisinopril or your enalapril. It would take the place of that.
Other questions?
Hi. Our daughter's genetic testing came back for dilated cardiomyopathy with nothing, but at Children's Hospital Pittsburgh, they told us, next year, 10 years from now, 15 years from now, something could be picked up and it could have been genetic. Is there some people that have genetic tests that were quote unquote normal? Is there like a clearinghouse for those? Will they know, do they keep track of the people's genetic, results for the future?
So theoretically, yes. But it is a good idea to stay in touch with wherever you or your child has their genetic testing done. The changes don't come by like every day or every month, but it is not unreasonable to consider, calling back to the center, 5 years later, just to say, my daughter had testing in 2014, just wanted to double check that there haven't been any changes in the classifications of things that were found or not found. I don't know, Alyssa, is 5 years, the typical recommendation? Do you guys?
You want to give her the microphone?
On the pediatric side, we usually say check in a year or two if there were any type of change that came up. If it was completely negative, we say 2 to 3 years. Things are changing really, really fast. And so we have additional testing options, new genes that are coming out, especially for pediatric cardiomyopathy. So get in touch if you have questions, or we try to keep track of all of our kids who we don't have answers for, but it's a lot. So getting in touch with us too, begging us is completely fine.
I was trying to prevent Alyssa's office from getting inundated with a million calls tomorrow.
That's fine. I'll take it.
But it is true, and especially if there were variants found, those can get frequently reclassified. And if there was quote unquote nothing found, most of the places that the genetic testing is sent will keep the DNA so that if there's a few new genes to test for, if they have enough left, they could potentially test for that without asking the child or the patient to submit a new sample.
But importantly, they won't do that automatically. So if you had genetic testing and, quote, nothing was found, then if there are new genes that we learn about and we would then look for changes in those genes, it won't be automatically done by the company. And that's the reason why you stay in touch with the center to say, are there new things we should test for? Should we do another panel to expand what we're looking at? As opposed to the second question, which was something was found, but what bucket did we put that answer into? Did we say this is causing disease, this is not causing disease, or we're not sure? And if that classification changes, again, you'd want to know, does it have implications for the family?
I think that becomes even more relevant if we start to hear about precision medicine things actually coming to the forefront and having treatments specifically designed for folks who have a specific genetic cause identified. And then also, if someone's coming up towards reproductive age, that's another time to start thinking again about what genetic testing has been sent and would it change what we're doing or what sort of advice we'd follow. Answered all the questions?
Mine is not actually a question. It's actually a shout out to Big Pharma, because I think people see these years and years of drug research that are carried on, and that the millions of dollars that are spent in drug research. And I think that in the press and everything, everyone's slamming Big Pharma. And I think that people need to understand why the cost of drugs seems so extreme. There's just years and years that they're not recovering any income. So as a pharmacist, I've been supporting Big Pharma, many, many years, because people complain to me about the cost of medications, and I understand why they cost so much, but I think it's a big shout out to these companies that are investing lots of time and money in these new drugs. So that's my statement, not a question.
Hi, my son Jack has been followed by CHOP since he was about 9 months old, and he was diagnosed at age 3 with LVNC. And now that he's 11, we were always told that we have to watch when he enters puberty, that the hormones are going to affect the heart and we're going to see changes. So my question is, what kind of studies and research are out there? Because I've seen a lot with the DCM and the HCM, but what is there for LVNC? And what are changes that we should be looking for? Why does that happen with the heart?
That's a lot of questions in there. Thank you for that, because I feel like sometimes LVNC is sort of one of the forgotten cousins of cardiomyopathy. And one of the reasons for that is, honestly, there's so much variability in what LVNC looks like for each patient. So practically speaking, what does that mean for someone like Jack if he's got LVNC and he's going through adolescence? It means we probably ought to take a look at him a bit more frequently, or just make sure we don't lose track of checking in and seeing how his heart is doing. In terms of what research is going on, it's hard because it can be so variable. LVNC often has, it gets paired with, is it a dilated type of LVNC or a more hypertrophic type of LVNC? Or is it an LVNC that's associated with another condition? And then sometimes you're like, no, I just have LVNC. And so splitting off into all those little categories means that there's not quite as much research targeted at LVNC specifically without other associated identified conditions. But we should do better, right? We should do better, and we should be looking more. Yeah.
The good news is we've put together an NIH grant proposal, so to the National Institutes of Health, an international group, including us, Stanford, Cleveland Clinic, a center in Korea, a center in the Netherlands, and we've proposed to do just that, which is do a more basic study of non-compaction and what it looks like and how we might target treatments. So that grant is put in. We don't know if we'll get it or not. We've tried a couple of times, but we're not going to give up. So we'll start by better imaging techniques. So looking at CAT scan, MRI, echo, and what your heart might look like that's spongy. How can we, again, categorize that so we can understand what caused it and how we might treat it? There are cases of people who have low blood counts, just anemia, and if it's in an extreme way, your heart can look like non-compaction, but you treat the anemia and it goes away. And people who are pregnant can have a non-compaction look to their heart with trabeculation. But again, after the pregnancy, it goes away. So there's a lot more to understand about non-compaction.
Hi. My son has LVNC as well, and he's been taking the NanoPro since he's been born, for the most part. So based upon your research and your information, is that eventually going to be phased out for the other medication that you guys talked about throughout this presentations?
Right. It's hard to say because if someone is only on one medicine because they're doing so well, we don't often look to see whether they need the more cutting edge, because it's usually the ones who have the more severe heart failure that get studied first. So I do think it's probably going to take a little while before those studies trickle down towards the children and adults who are less affected. It's not less important, but it's just not where you see the most dramatic improvements, for example. So to prove that a drug or an intervention is effective, sometimes you have to go after the patient population who can show the most benefit and the most change. So we're not going to have data behind that right away, but hopefully we'd eventually get to that. We may also, just to give a corollary to that, get more comfortable with the side effects, the benefits of the newer medicines, and then be able to speak to families and patients with more experience behind us as to whether we think it's appropriate to switch over to one of the newer agents.
That some do really poorly very early, but then some actually get improved. Yep. I just wonder if you could talk about why would it be that the same diseases the kids would actually get better, whereas with most adults, I think you were saying most sort of gradually get worse? It's
a great question. I wish I knew the answer to it. We really don't have a lot of ways to predict who's going to do well and who's going to do not when we diagnose them. The things that we do know are helpful are very crude, like being younger is better than being older for a child. So a baby has a much greater chance of recovering than a teenager when we diagnose them. And the size of the heart. So the worse the heart function is, the less likely it's going to get better, and the better functioning, the more likely. Beyond that, we don't really have good ways of predicting. I do suspect the underlying disease makes a difference, so that there are certain, abnormalities in the genes that are worse than others. In the studies that we've had, that's not actually been clear, in part because for each abnormality, we oftentimes don't have thousands and thousands of patients that share the same, underlying genetics. With the exception of things like Duchenne muscular dystrophy, where it's dystrophin, protein in everybody. But part of the things that we're very interested in at CHOP and at Penn, and then just throughout our community of people around the world that treat these kinds of problems, it's to really better understand how can we predict who's going to do well, who's going to do not, and what therapies we have. But as of today, we just don't have great predictors. And children, for sure, maybe adults are better at it than we are.
Even in adults with our families, we'll see the exact same genetic change present differently in a mother and a daughter, or two sisters or brothers, the exact same genetic change. So that makes us think that it's more than just your genetics and what you're born with, your DNA, but really the interaction between your DNA and the rest of your environment. And so what we've learned over years is that viruses and what we used to call viral cardiomyopathies, and some people may have been told your heart's this way because of a virus, is probably actually you were born with a genetic predisposition, you're at risk for it, and then in comes a virus or a pregnancy or a medication that's given for cancer, and that tips off your heart to change and show the cardiomyopathy. So there's so much that we don't yet understand about the interplay between your blueprint and your environment. And my guess is that may have something to do with why people present differently.